J. Ahmed. So we'll be happy to have him. And then please make sure you take notes and make sure you also write down your questions so that at the end of the session we'll be able to discuss. So thank you, Dr. Ahmed, for creating time. What time is it in Canada? Maybe is it 2 a.m. or something like that? I'm not sure. But thank you for creating time to stay awake to talk with us this morning. So we'll listen to you for some time, then we just have a discussion. The discussion is not going to end today. The discussion will continue for the rest of the week in our chat group. So, Dr. Ahmed, you are welcome. You have the floor now.
Thank you very much, Professor Dofia. I really appreciate this. And thanks to TJ for being on my case. I'm not this recalcitrant, but unfortunately, the demands of time has made it difficult. My name is A.G. Ahmed. A lot of people moderate, they either call me J. Ahmed or they call me A.J. Ahmed. A. Adekunle, the middle name is Garba and the last name is Ahmed. I'm a bona fide Nigerian. So I'll be talking today uh, about I was told to talk about CBT generally. So this is going to be a series according to TJ. Oga gave me orders. So TJ, I'll do exactly what you've said, but I thought I'll start from comfort zone. Um, I, I make some declaration before going.
Yeah.
One is that I'm an Elysian to the core. I follow Albert Ellis in CBT because we believe that we're really the we're really the original CBT before Beck came along. So I'm not a Beckian, I'm an Elysian. We can debate that later. I'm not a psychoanalyst. I like to move things along. As a forensic psychiatrist, I, I look at risk. And therefore, in my practice as a psychiatrist and as a forensic psychotherapist, it's better that I get result on time because the safety of the public is paramount. I can't wait for a long time to get all those I understand, I mean, I use psychodynamic theory in understanding my patients, but then to treat them, I need to move very fast. These are my declaration. Uh, this is a declaration of conflict of interest for those who are interested in that.
Sorry, Prof. We
And
cannot see your screen yet. If you can click on
you
the
can see my
box.
screen. Oh,
Yeah, if you can click
geez.
on the box to so that we can see it.
Can you see now?
Not yet, sir.
It says stop sharing. It's sharing.
No, if you click stop sharing, it will not share again. So you can share again, sir. Okay, kindly
So it's
re-share, sir.
okay. I'll go back. So,
Thank you very much, sir.
what happened to Zoom?
It's a different platform
Okay.
from Zoom. That's why it's a bit tricky, sir.
Share screen. Okay.
Yes, sir.
Are you there now?
Yeah,
My apologies.
no problem, sir.
Get this first.
Concerned with the prevention and cure of mental disorders and their sequels.
Am I sharing now?
Yes, sir. Perfect, sir.
Okay, good. Sorry about that.
I
Now
see
I
a
have
difference.
to move my slides, but it's not moving. What's going on? Oh, good.
Concerned with the
So
cure
I've
of
done my
mental disorders.
declaration. The objective at the end of this hour, I'm hoping that I will have introduced you to REBT as a form of CBT. I hope I will have covered the theory of emotional disturbance and change in REBT. I hope we'll be able to identify rational and irrational beliefs or those cognitive distortion. And I'm hoping that I will have stimulated your interest in REBT. These two guys are the culprit. To the left is Beck. Beck is a physician, and Al is a psychologist. Beck at the beginning wrote essentially for physicians like yourself, busy physicians, and want Both of them were fed up with psychoanalysis. It took a long time. Al, in particular, was a psychoanalyst. Out of protest, he got out of it, and the two of them decided to go their separate way. In 1952, Al then created um, RET, Rational Emotive Therapy, RET. And basically, that was based philosophically on Stoic phenomena. And you will see that in his writing, he quoted a lot, and it seems as if he wrote for the layperson in his writing. But the two of them initially they were working on cognition, and they believe that cognition is the basis of emotional disturbance. And that if you can grasp what is happening in your cognition as in thoughts or belief, and you're able to change it, then your job will be easy. And that was what led to Al theorizing about the principles of RET, Rational Emotive Therapy. But after about a decade in this practice, they got fed up because it wasn't followed with action. And that's when both of them individually introduced the concept of behavior. So it was cognitive therapy, Beck, rational emotive therapy, Al. And after they've tried it, then brought Warp's idea, behaviorist idea, that is the biological basis. They brought it in, and then you have rational emotive and cognitive behavioral therapy. This is our center, the Canadian Center for Rational and Cognitive Therapy in Brockville. The picture is better now. This used to be the picture from so many years. So let's talk a little bit about introduction. Developed, as I said, by Al in the mid-50s. The aim is to change irrational belief that contributes to emotional distress, and it focuses on cognitive processes that can be modified. And what we're going to be doing is identifying this last two here, especially cognitive processes and how you can go about modifying it. Let's jump to it quickly. Rational emotive behavior therapy is based, you will hear a lot about the A, B, C model, and there's the D and the E. But what then is A? Al believes that every human being has a goal in mind. In our life, you want to be the best that you are. You want to achieve certain goals you've set for yourself at any point in time. However, in the course of your journey towards your goal of survival, of living, of being a human being, there are adversities and negative experiences in our life, in a person's life, and we refer to those as activating events. This activating event can occur in the realm, can occur within yourself, which may be your behavior. You behave badly, like not knowing how to operate. I can't even call the mode of virtual presentation. From my thoughts about this, the anxiety that is associated with me preparing this, or memories of what I've done in the past that really messed up my presentation. That could be an activating event. It could be the behavior of others, like TJ insisting that I ought to present today and making sure that he prepare a program, an announcement, and just fired it even before I said yes. Or it could be the world. Trump decided to place a tariff on my country and alienated the world. Those are activating events. And these activating events are associated with some consequences. The consequences can be emotional consequences. So you jump to see right away the consequences because most of the time we're not aware of the B. And this B can be, C can be emotional consequence. I could feel angry, I could feel anxious, I could feel depressed. And the behavior can be that I attempt suicide or I go ahead and punch my computer when I got frustrated with not being able to use the program. However, behind this, according to all and the philosophers, is that there's a bunch of thoughts going on. The thoughts about the self, the thought about others, and the thought about the world. And these thoughts are strong beliefs that come from the inferences that we have about the activating event. They could be specific or generalized. So most of the time, we only see the C associated with the A. What we talk about is that you made me angry, I feel depressed, and so on and so forth because of what's going on in my life. We're really very oblivious of the B. So that is the sort of framework that we use. However, REBT has gone through evolution over time. As I indicated to you, the same thing this Beck did was what Al was doing, except that Al went deeper, and I'll prove that as we go along. So the foundation, as I indicated, either for CT or cognitive behavior therapy, is the ABC framework of relating. However, these two also consider the theory of causation. The theory of causation is that you made me do this, right? That's the usual theory. My wife disrespected me and I got angry. However, the cognitive and emotional drives that come in from whatever is happening, we ignore it. So there's a need for us to identify the belief. So this is further elucidating what I've said in terms of activating event, which could be external, internal, and beliefs that can be divided into two. You have your rational beliefs, which are preferences, objective evaluation, quite scientific, logical, self-acceptance, and moderate frustration. That's what this rational beliefs look like. Irrational beliefs, on the other hand, are dysfunctional. They're characterized by the four main irrational beliefs. When Al started, he had about 12 of them. And then after a lot of research, it was consolidated into these four. And the most important irrational belief, of course, is demandiness, right? Then you have derivatives from this, and we'll go into further clarification of these. And it's important to know the derivatives because the derivatives is what lead to the particular disturbing emotion. So demand is the basis, and then if you authorize, you're probably going to be looking at depression. If you authorize, you're catastrophizing, you're looking at anxiety. If you self-downing, then you're probably looking at depression. If you look at frustration tolerance or you have low frustration tolerance, you're probably going to end up with anger. And of course, what happens next is whether or not your thoughts and behavior are adaptive. So, irrational beliefs, the theory of REBT is that irrational beliefs lead to dysfunctional and disturbed emotion, whereas rational belief lead to functional but negative emotion. Negative emotions are not bad. They're very good. They're psychological fevers. If you had a virus, you're going to have fever. The fever is telling you to do something about yourself, right? Similarly, if you have something that is an event that is precluding you or is threatening your progress towards your life goal, you better have a negative emotional response. If you fail an exam and you don't feel sad, forget it. You're going to remain there. You will never get your emotion. If your boss, if an examiner fails you, or you believe an examiner fails you, and you don't challenge the whole thing and say, hey, what's going on here? You probably never never achieve your goal. So negative emotions are very good and nurture them. The theory of change. According to REBT, there are various level of change. We believe that change can either be superficial, deeper, or fundamental. In fact, in REBT, classic REBT, medication, and I'm going to be offending most of you in this room, medication is a superficial change. I'll repeat that. Medication is a superficial change. The fact that I'm hallucinating and you gave me medication and that, corrected the dopamine, whatever in the brain is a superficial change within our theory. However, fundamental change is that even if the condition did not change, how do you continue with your goal of life? Let me repeat that. To give me medication to take care of the basis and say, I'm removing the A, the voices is superficial within our concept. However, let the voices remain. Let my persecutor remain. Let my idea at the time, the King of England remain, and everybody saying you're a mere pauper, A.G. Ahmed. How do I continue to live my life? And this has implication when we talk about the application of REBT to psychotic disorders or more severe mental illness. So therefore, our goal in REBT is to focus on modifying the core beliefs for everlasting change. Got it? For modifying those beliefs. And that's what we need to do when you're talking about change. So therefore, what are the the skills you require, that is required for REBT? REBT. REBT makes a distinction between practical solution and emotional solution. All right? Practical solution are directed at taking care of the activating event. So Trump has started with all his tariff or whatever. Practical solution, don't vote for Trump. That's one thing. Get enough people so that you don't. Trump never wins again. But you know what happened? He didn't win the first time, he's winning the second time. If you've not dealt with your emotional solution, you probably destroy yourself while Trump remains and destroys the world. So clients often come to you and they say they would like to change the activating event. That's the goal. They want it done. Whereas emotional solution is changing one's emotional response through the cognitive reaction to whatever the activating event is, rather than escaping. So in our theory, we believe if you're dealing with A, you're trying to escape A. So REBT posits that it is best to go for emotional solution first, all right, before you pursue, I'm sorry, before you pursue practical solution. It is more elegant, it is more lasting. And there's a basis for that. If you look at your Jack Dobson's curve, in Jack Dobson, you talk about, performance anxiety, you reach the performance anxiety, your best performance, and if it persists too much or whatever, you start going down. So we need you to get to that level where you have enough emotion to effect a positive change. At a higher emotion level, you may not be able to do a good goal. REBT goal, therefore, does not state that you focus on only emotional solution. We also say that after you've regulated your emotion, you can always do a better job of having practical steps that will help you achieve your goal in life. So practical solutions are part of the system. It's part of your theory when you want to change emotion in REBT. What about the difference between functional and dysfunctional emotion? This is a very important aspect of REBT. We believe that there's a qualitative rather than just quantitative difference. It's not a question of me being angry or not being angry. Anxiety qualitatively, anxiety can be qualitatively different from concern. They're both galvanizing negative emotion, but they have qualitative differences. And it is better to be concerned rather than to be better to be concerned than to be petrifyingly anxious, because that stagnates you. So, what are the four aspects of emotion generally? And this is not restricted to REBT. Whenever you describe emotion, whether you're aware of it or not, these are the sort of thing you have in mind. One is the phenomenology itself, phenomenological. What does it feel like? Two is the social expression. How do I communicate, or how do other people see me in pursuit of my goal? The social expression. Three is the physiological, the stress response that you experience. And the fourth one is your behavior. So for every emotion, these four components. Surprisingly, the only one we can measure of all this is the physiological. The others are qualitative to some extent, because right now, with EEG changes, we're able to measure some other aspect. However, for the sake of simplicity, we're saying the one that you can measure is actually the physiological, which is quantitative, but others are qualitative. And that sets you free. If it is qualitative, then I determine to what extent my feeling goes. You do have that power, regardless of what happened. So this is the kind of model of arousal that we look at. Wall pain, subjective unit of distress versus the traditional model is that it's functional at zero. Don't be angry. That's what your grandmother told you, right? Okomimabinu. Don't be angry. Whereas it's dysfunctional. Yes, he's so angry, but everybody forget that Jesus went into the temple and drove those people away that his they turned the church, his father's house, into the mall, deviating. So it's not a question. So this traditional model of functional versus dysfunctional at 100% is it doesn't apply to life. What about REBT? REBT then said, no, 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 no. Functional emotions are distinct from dysfunctional emotion. All right? Functional emotions are totally different, and you can have functional emotion from 0 to 100. Dysfunctional emotions are also different. They belong to different classes. Well, Dryden said, no, 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 no. What we do is that although they are different, however, there's an overlap. So you can have functional right from the outset, right? Guilt is a dysfunctional emotion, whereas remorse, I said, come on, you're being semantic here. What are you talking about? There may be no difference. Of course, there's a difference, and we'll talk about it. So, functional and dysfunctional emotions overlap. And this is very important in helping the patient understand. Irrational belief leads to dysfunctional or disturbed emotion, whereas rational belief leads to functional, negative emotion. If your clients are not willing to seek emotional solution and only desire to escape the activating event, it is important for you right from the outset to set the rationale. And therefore, you will have to be very clear about what functional emotions are and what dysfunctional emotions are. And make sure you get an agreement. If you don't get an agreement, you're going to be in trouble. You'll feel criticized. The other area that we need to think about is the three levels of thinking. And this is where the Beckians differ from Elysians.
The Beckians we talk about, the three levels are inferences. And inferences are what? They're guesses about what is happening. It doesn't mean that you're right. I infer based on my narration, based on my experience. But you're a fallible human being. You've inferred in the past, you've made mistakes, you've made some poor judgment in the past. So inferences are guesses. They're not factual, they're not scientific. You may be wrong, you may not be. Evaluations are judgment based on inferences. Because each time I've presented around 3 a.m., I've given a talk around 3 a.m., I've fallen asleep midway in my talk. Therefore, I'm a bad person when it comes to presenting at that time. What does that mean? It doesn't really confer a lot of information that is helpful. So, and the second aspect of it that we tend to ignore are the core beliefs underlying those evaluations. So you have inferences, evaluation, and core belief. Elitians would tend to believe that Beckians restrict themselves to the first two, inferences and evaluation, global rating, judgment, and so on and so forth. They stop at that. They forget about the third one, and we believe that the third is the most important when it comes to identifying or helping people to advance and deal with their emotional problem. Let's try to look at core beliefs again. So we've classified core belief, we talk about rational belief, and we've talked about irrational beliefs. Now let's go for the irrational belief. Irrational beliefs have two components. The process of thinking itself can be irrational. However, the content can also be a problem. So therefore, in your job, in helping your client, you've got to identify the process that is a problem, and you've got to identify what content of the belief the problem is impacting. These are the four irrational processes. I mentioned them before, but we're going to talk about them in greater detail. Demandiness. This is believed to be the most important core belief or irrational process in all human emotion. Demanding. It all starts with demanding. Just like the psychoanalysts, we talk about repression, demanding is considered to be most important. It is then followed by global evaluation of human. Remember, I told you you're going to have it in 3 dimensions, 1 or 3 directions: self, others, the world. Global rating, then awfulizing or catastrophizing, and frustration intolerance. So you have demandingness, which is followed by global evaluation of human. Depending on the direction, your pathology will appear. I demand that people must be of certain religion. And if they are not of that religion, global rating, then they are not worthy of living. Terrorism. You got it? Global rating. I demand that I must give a perfect lecture. If today I get the feedback, lousy lecture, did you understand a word of what you said? Then I say, I am so worthless. What do? Depression. And I may become suicidal. Anyway, you got the gist. So, the essence of emotional disturbances I've indicated is demandingness, and they come in these forms. I must. I have to, I got to, I need to, I should. That's what your patient will be saying. This is what you'll be hearing from the content of their discussion. Directed at others, you must, you have to. You've got to respect me. Directed at the world, it must be a perfect world. It has to be a perfect world. Those are the kind of notions. The patient may not use this word, but those are the kind of notions that underline the expression of demandingness. And I've indicated the direction of demandingness. Derivatives then, in the process, the next one is catastrophizing. It is horrible because the demand didn't hold. It is terrible, it is awful, and therefore you have anxiety. I can't stand it. If you can't stand what do? You shitify it. What do we do with shit? You flush it down the toilet, basis of anger. And then you motivate your internal energy to really strike at the person. That's the basis of anger. What about the self and others? I'm no good, you're rotten, I'm rotten, and then you're worthless, and so on and so forth. Summary. All serious emotional disturbance is caused or strongly influenced by our thinking process. And this cognition takes the form of a demand, e.g., I must be successful. And one of the derivatives, and depending on the direction of the derivative, you then have the next step, the type of emotion that follows. But you must have had all this before you go to automatic thoughts. Automatic thoughts, I told you, are inferences and evaluation. They're based on repeated ways of you drawing conclusions, right? You've drawn conclusions, you've evaluated it, so that's what it's based on. However, behind that are the demands and any derivative that follows. All right. Demand and preferences. You need to make we need to make a sort of very good clarification here, because this is the basis. Demand leads to problem, but preferences lead to a fulfilled life and get you to your personal goal. So what you want to work on is how to change the demand to preferences. I must, in the preferential realm, come to I really like to, but no reason why I must achieve it. I really like to help this group, but there's no reason why I must. No. You really want to stay to the end of the letter, but there's no reason why you must. That is true about life. Catastrophizing. It is horrible. It is terrible. No, it is bad, but it's not the end of the world. Low frustration tolerance. I can't stand it. Bogus lie. Because you've stood things like that before, otherwise you'll not be here today. The fact that I failed an exam, I am rotten. I'm disadvantaged. I'm disappointed in my performance, but it doesn't make me a rotten person. So your task as a therapist, as a psychotherapist, is to identify the person's maladaptive cognition, the demand and the derivative, and actively and persuasively challenge the patient's maladaptive cognition. You are a benevolent teacher, and that's what you want to do. You give the patient practice in actively challenging their maladaptive cognition and give them self-improvement exercises that we talk about. So that's about the process. Most people think that REBT stop at process. However, this subtle, deeper meaning about what is the meaning, what is the content, is lost to most people. And you got to pay attention to this. The content are of 5, whatever you want to say, 5 types. Broadly, you can classify them no matter what you do. A lot of research have been able to classify. One is about approval or rejection, acceptance, which mean approval is you accept me or you reject me. The fear, the desire to be approved. The second is achievement, success or failure, right? Comfort is the third one. And the fourth one that is common to most humans is power. I want to be in control. The violence that you see among male and female spousal abuse and even the antisocial personality is talking about power. How do I control the other person? And then you have the idiosyncratic issue related to the patient. This is where your bipolar disorder and your patient with schizophrenia come in, the kind of content. It is idiosyncratic. I'm a poor village boy from Abaya in Lorry. What gives you the impression that I belong to the royal family? What got into my head other than maybe some grandiose delusion that I'm a descendant of the Queen of England? That is idiosyncratic. But REBT takes care of that. So this idea that psychotherapy is not useful when it comes to treating psychosis is hogwash, right? This idea that psychotherapy is not good in, and this was a brilliant argument that I had when I was training with Al. He said, you're a psychiatrist, a forensic psychiatrist. What are you doing at the institute? And this was when Timothy McVeigh did the Oklahoma bombing. What are you doing here? You cannot change psychopaths. We beg to disagree. You cannot treat schizophrenia, patient with schizophrenia with psychotherapy. I beg to disagree. And that's a topic for another day. But this idiosyncratic issue, you got to listen to it. Just quickly, when you talk about emotion, the common emotion that you all deal with is depression. So let's try to, this is complex, but it's supposed to help you connect Beck and Elysian. This is what tends to happen. Depression, that's the emotion that you see. And depression can come from this perception, the automatic thoughts, and negative attribution. This is the area that you're working on. As a psychotherapist, you want to change this, you want to effect change here. Most Beckians, we say, look at the evidence. You passed so many exams before. Why are you saying that because you failed these, you're now a bad person? That's just, oh yes, I've done this, I've done this. What about the one time that you did very well? Automatic thoughts, negative attribution. It doesn't mean that this is the totality of you. Your area of practice at this level when you are doing Beckian CBT is just at this level. And we'll talk about this some more at our next lecture. However, in REBT, we believe that the area of concentration is called schematic irrational cognition, which are those things that I talk about with regards to the process of thinking and the content of thinking. If you're able to do that, then you're able to affect the perception, you're able to affect the automatic thoughts, and you're able to change the negative attribution in a deeper manner. Okay? Are you still with me? Are you still with me, or am I talking to
Yes, sir.
myself?
We are still with you, sir.
Okay, thank you very much. So this is challenging the schemas. The mental schemas are cognitive experience expectancies about reality, right? There are expectancies and there's reality and there's discrepancy. I went to school, and like anybody that went to school and went through medical school before me, I'm guaranteed to have a job. So that's my expectancy. But the reality is that by the time you finish to get house job is a problem. There's a discrepancy, right? my seniors and everybody, oh, you went to school or whatever, my parents. That's why Nigerians pour money into education. That's why we read and read like whatever. Because we are saying there's a guarantee we have something that we're expecting. But there may be a discrepancy based on a number of factors. Now, when you see this discrepancy, you have two things to do. Is either you assimilate, i.e., keep your expectation the same in the face of reality. My expectation is to have a good paying job, and therefore I must have a good paying job as a doctor. I'm not budging on that. It is not in keeping with reality. There's a discordance, there's a discrepancy. You can sit down on assimilation and say, no, I'm going to keep it. Oh, you can accommodate. So you build a little house in your brain where you say, this is my expectation, but my reality is not jiving. And that is a form of adaptation. Most of the time, assimilation causes trouble. It causes emotional distress of different kinds, whereas accommodation causes flexibility that is compatible with a fulfilled life. Got it? It is compatible with fulfilled life, and that's what your goal should be. Not all schema accommodation lead to anger. The most problematic is the schema concerning existence of things we want. I want this, and we confuse our reality with what we want. Growing up, I wanted to have afro for the rest of my life, right? By the time I got to 30, I started losing my hair. Man, what do? I got to rock my baldness. The shavers come through, and I shave. And then to compensate, I retain my facial hair. That is the way to accommodate facing your reality. So, how then do you help your clients to change? You understand the emotion and you understand behavior. You say, this behavior, what is the underlying emotion? And then you understand that these are caused by beliefs. Let me make a clarification. I use beliefs, thoughts, cognition as synonyms. All right? So you understand these and uncover the relevant behavior using the ABC format that I talk about, and then identify what the B is, dispute and change those irrational beliefs and replacing them with rational alternatives. Then you don't stop at that, because the mistake Beck and Al made was to stop when they got to 3. For the first decade of the practice of CBT or CT and RET, Rational Emotive Therapy, they stop at 3. Then later they introduced the behavior. You got to change your behavior. Boom. Rational Emotive Behavioral Therapy. So you got to find out. What are the prerequisites then for disputing irrational belief? That is challenging those core beliefs. So if you follow my discussion so far, I've said the most important thing is to help your patient change from irrational to rational beliefs, from self-defeating cognitions to self-fulfilling cognitions. What are they? How do you do that? Is that a challenge? And some people have accused us in REBT that we tend to argue with our patient. No, we don't argue with our patient. It depends on your style. We challenge those beliefs. We look at reconstruction of those beliefs by helping them. So, what are the prerequisites? One of the things you probably need to do is to first of all help the patient through Socratic exploration to arrive at the conclusion that the current emotion is dysfunctional. My anger, my anxiety is dysfunctional. It's not helping me to achieve my goal. And to talk about achieving alternative and acceptable emotional goal. Yes, I'm anxious about my daughter, teenage daughter, becoming pregnant. That's why I keep yelling at her. And then she'll run away with a drug dealer anyway to become pregnant. You better accept it and say yes. So instead of being anxious and then you have a secondary emotion, anger, I may be able to say maybe if you have concern, because concern is a functional emotion, and you help them to understand the difference between the two. Then you help them to understand the connection, what we call BC connection, rather than AC connection. The mistake we make as human beings is to make AC connection. You made me angry. No, it's to say your behavior through my beliefs got me angry. So you got to do the BC connection. Therefore, change the belief, and you can be who you are, and I will change my dysfunctional emotional response. So the process of therapy includes engaging the patient, building rapport like in any psychotherapy, assessing the problem, guiding the client's perspective. Why? Prepare for therapy, set the clear goal, explain what you're going to be doing, the ABC framework, evaluate and assess improvement, periodic summary, and prepare for termination. There's some cognitive, and I'll be stopping very soon, cognitive techniques such as rational analysis that we do, imagery. Uh, there's also other behavior techniques like shame attack, exposure therapy coming from behavior therapy, and REBT tend to use a lot of self-improvement exercise. Remember, I told you, Al wrote for the public. He was like a typical philosopher who wrote for the public. Thought experiment. Thought experiment is just an example of the techniques that it involves just Socratically asking the individual and say, how is what you are saying rational? My husband comes home late and he has done so for whatever. He's done so for the past 13 years that we've been married. You multiply the numbers and say he has done so over 3 million times. And you say, you can't believe that, but they will come home late. What are you talking about? So you challenge that and so on. That's what thought experiment, the details of it. I'll send this slide to you. Demand about reality and preference from, that's what you, preferences of, about reality of preferences. Yes, you can want what you want, but to say it must happen is a problem. And then, I mean, this sort of, this is a belief, a sort of philosopher saying that really resound, if you've been listening to me, in your understanding of how the mind works and how we can change it. If you challenge the beliefs, see, I've talked about challenge, but if you challenge beliefs prematurely without preparing your patient, they may feel invalidated. So this process may look simple enough, but you've got to prepare yourself. Otherwise, you run the risk of invalidating your patient. And the way to avoid that is to acknowledge the desire. It's good to desire the best for you. Remember, I told you about the journey of life. The journey of life is to be the best that you can until things happen. As a result, do not challenge expectance, but you challenge the belief that what I expect must happen. So these are steps in challenging what we're saying. So it's just for you to develop a rational replacement of idea. Just because I want to be X, right? or I want X to happen does not mean it must happen. That realization is actually a green light for progress. If you get your patient to start thinking this way, you've made a headway. Okay. And this is some of the how you challenge the derivatives. All human beings are equal, to say, and including yourself, and you're equal at any time. You are the same person when you succeed. You are the same person when you do not succeed. So condemning you is it doesn't is not compatible with the reality. Any description at any particular point in time is culturally limited. When I was growing up, to be a criminal in Nigeria is a problem. Today, what happens? You become the Senate president. Sorry if I'm offending some people's sensibility, but that's the truth, right? You want to go into the police force? No, if you went to medical school when I was growing up, that was the self-worth, right? That's why all our parents spend their retirement sending us to med school. Today, you can go to med school, you won't even get house job, or talk less of getting a job. So it's time limited. You cannot globally evaluate people. Doesn't make any sense. Yeah. Low self-esteem leads to depression, shame, and guilt. So if you follow that trail from demanding, global rating, or evaluation, it can lead to low self-esteem, and low self-esteem can be associated with depression, guilt, and shame. High self-esteem can also lead to anger. That's if you look at your antisocial personality, guys, that's what you're dealing with. And we make a terrible mistake, all of us. That's why I have that. Particularly psychologists among us, they follow this nonsense and say low self-esteem is the problem. You got to have high self-esteem. It doesn't matter. It's unstable self-esteem that is the problem, right? So you got to work on the dichotomy between low and high self-esteem. Catastrophizing, what does it mean? A lot of them say, oh, it's terrible. I cannot stand it. I cannot stand out. Me, I went to school. Huh? I cannot stand it. My children go read music. How can that happen? I'm a professor of medicine now. How can my child go and read music? It doesn't. Well, it will be terrible. And then you get to explore that. What does that mean? More than 100%? Are you the worst? The most poorly defined irrational belief is catastrophe. When you're talking about catastrophizing, is it 9/11? This is more, so you got to make it, you got to define it in relation to your culture and who you're dealing with. Again, you got to be very careful, especially when you're dealing with the PTSD patient that have PTSD. If you start challenging or you are challenging the catastrophization of their experience without making a distinction that is the belief, or you challenge or dispute that derivative too early, you may rupture your relationship. So you've got to be careful. So you may want to go from goal-directed exploration. What about frustration tolerance? This is a belief that one's intolerance to survive or stand discomfort has a limit. I can't stand it. I can't stand the student coming. I remember in med school, you don't wear a tie. I can't stand a student coming without a tie. I forgot my stethoscope, so what? I can't stand a student coming without his stethoscope. Get out of that was what happened. Public shaming. That's why some of our generation, we have difficulty with the changes that we're seeing now, because we have these inferences and evaluation that we've got ourselves stuck on, that now gave us this picture that everything must be this way. It is too hard to do things. I've had enough of your SHIT. Ellis uses the term low frustration tolerance for these limits, self-imposed limit setting to the capacity of human, right? This is something that, this can be invalidating to those who have experienced, when you are challenging it, who have experienced the most painful PTSD patient again. But if you do it elegantly, your goal is to create high frustration tolerance. But your high frustration tolerance may not be sufficient for their goal. So this is where further exploration is important depending on what you're dealing with, right? And this is summarizing the fact that you believe that I can't stand it, I've reached my limit, therefore I'm going to do this. This is a difficult issue with people who have suffered trauma. As I've indicated, they may have suffered from more than most people, but they define it by themselves. So it's for themselves, and by themselves is individualistic. So you got to look within the power that they have. And this is where the framing works perfectly, right? Rather than see yourself as a weak person, as a traumatized person, why don't you see yourself as a survivor, somebody strong, so you can reframe it. So reframing becomes something that is very helpful when you come to this. So what are the unique features of REBT? REBT talk about absence of self-evaluation. You don't evaluate yourself. You are who you are. You are a human being, period. You're a human being who most of the time actually aspire to be good. But sometimes you mess up. That even helps you as a therapist to accept your patient, right? Recognizing the recognition of secondary disturbance. Problem about problem. You may have genuine anxiety concern about your daughter going out at 18, but then it's followed by guilt about that. Then the guilt may lead to you taking steps that is a problem. So understanding that you have an emotion, negative, that is expected, and ensuring that you take care of the secondary emotion, and specifically in REBT, you do meta-emotion analysis to get the patient going. The question of discomfort versus ego, discomfort disturbance versus ego disturbance. We do very good. We spend time doing this sort of clarification, particularly among those individuals who have substance use disorder, because in substance use disorder, your approach also differs depending on the stage. There are about 6 stages of severity of substance use, and you will have to clarify so that you have the right technique. So, learning to use REBT will involve irrational thinking, recognizing irrational belief, attending training courses for professional development opportunity, and practice self-exercise. This is a slide that summarizes all that I've talked about and taking it to D and E. And so application of REBT, as I've indicated, or must have alluded to throughout my discussion, is not limited to any particular disorder. You can use it in depression, anxiety, eating disorder, anger management. That's what I do most of the time, and I use REBT, and it doesn't matter, it's transdiagnostic. Non-clinical setting, personal development, workplace. There's a lot of literature on workplace and how you can apply REBT principle. We use it in individual setting. Group setting, we have a manual on REBT that we wrote for the treatment of addiction, adapted by Smart USA, family therapy. All this principle can be applied. Remember, freedom to choose your emotion and behavior. Even if when you're psychotic, that will set some people up that we may not be able to finish that debate. Even when you're psychotic, you can apply REBT because it gives you freedom to choose. Focus on thoughts, emotion, and behavior. Regardless of what's happening, focus on thought, emotion, and behavior, and identifying this specific connection between thoughts and disease. Our approach is selectively eclectic, educative, and collaborative, and it's time limited. It's not forever and ever. Amen. I'll let you read this as I round up. And this is more rational analysis that you can go through. If you're interested, I don't think I can do this, but I'm going to stop now. I know I've past my time. In case you're interested, there is fundamental training level 1, level 2, level 3, and certification. And these are some references. This was the picture that was taken in 2001, and that's Al and my classmate during the fellowship at Albert Ellis Institute. Good morning. I'll be happy to take questions. Hello?
Thank you very much, Professor A.J. Ahmed. This is a very fantastic presentation. I'm sure with time, Professor Dufia will join us again. But this is the section, like you said, for question, answer, contributions. And some people have raised up their hand that they want to participate. Please, Dr. Obank, you can go ahead.
How do I get out of here?
Uh,
Okay, thank you for the insightful presentation. I learned a whole
just
lot.
click end to. Sorry, hold on, Dr. Obank. Just click end to your slide. Click it, and I think you'll be out. Then we'll all have a common share screen. Thank you, sir.
Okay, thank you. Please go ahead, Prof.
Okay, please go ahead, Dr. Obang. Thank you.
All right, so thank you for the presentation. It was very insightful, and I learned a whole lot. My question is on the slide that you mentioned, time. I think on the derivative on imagery. Imagery. You mentioned
Mm,
that blowing it out and then time something. I wanted to know more about the first example of the image, that time thing. I don't know what slide that is, but that's what I want to know about. How is that done?
okay,
The
okay.
second question is on trying to get the beliefs. I know that in
Mm-hmm.
CBT we use the laddering technique to come down to get the automatic thought of the core beliefs. Is it the same
Mm-hmm.
process with REBT? Then lastly, what's your experience with REBT on Nigerians? I don't know if majority of Nigerians are rational or they're more sentimental. So what's your experience been doing REBT on Nigerians? So thank you.
Thank you very much. Have I stopped sharing? Have I? Because
Yes,
I
sir, you
can't
have
see.
stopped sharing. Thank you, sir.
Okay. Yeah, I'm trying to get back to wherever. Anyway, I'll keep talking. If you can see me, that's cool.
Yes, sir, we can see
The
you.
first question. There's so many techniques. You're talking about the blowing it out is catharsis. If you want to look at it, that tell me exactly what it is and get it, and you can go by extension. You have people who say, our trauma really. You have people who say that I'm so angry at the perpetrator of my abuse, and and I'll say, what would you like to do if they were in front of you now? And you let them blow it out in front of you, they say, I'd like to beat them up, and say, okay, you beat them. What else? I would like to spit on their face, and what if you spit on their face? And my ASPD patient would tell you that I'd like to kill him. I say, you've killed him. What will you do? I'd like to chop him. Sorry that I'm being grotesque or graphic here. I'd like to chop him to pieces. Yeah, you've chopped him to pieces. What else? And then, the emotion rises and then they calm down, say, I don't know anymore. And that's the way to say, okay, now you've done this. How does that help you? You're trying to use it to chase that dysfunctionality. You're still left with the problem. So let's change your thoughts about it. So that's the way we do it. The second question is getting to the core belief. Getting to the core belief, we tend to use more Socratic questioning. And it depends on how sophisticated your patient is. Because you can do inference chaining and all those methods that you use normally to further explore conjoint sentences and so on. You know all this. You do it, and then you have the individual starting to use words like, it shouldn't be that, it shouldn't be this. Then you start defining what should is. Are you saying it should as it would be nice? That is me now talking about flexible language. It is very linguistic in your approaching. Is it? It should as it would be nice, or it must happen. Of course, it must happen. What are you talking about? She's my daughter. And you see the emotional reaction, just like I've tapped on the table. That's the sort of thing that you're looking for. So, inference chaining, demonstration, paraphrasing, and rephrasing their statement to seek clarification. Now, it may fail. When it fails, in such instances, that's when you bring out uh, Dryden's method. Dryden would then say, this, he will make a demanding statement to reflect the cognition and a preferential statement and say which one applies to you. When you are feeling angry, when you are yelling at your boss, are you telling yourself that my boss must treat me with respect? Or are you saying, I wish this man treat me with respect? What are you saying to yourself? Think about it, Dave. And then you say, of course, the guy ought to treat me with respect. Boom, you got your demanding belief. So that's what we do. Application of REBT in Africa, within the African context, not only. I've given lectures in South Africa, the same thing among all of us black. The first thing is that we like the word for emotion, right? And English language itself is very lousy when it comes to emotion. We have great debate at the institute about disgust. What does it mean to be disgusted? So the problem you're going to have with the application of REBT is actually the clarification of emotion. What is depression in Hausa? What is depression in Igbo? What is depression in Yoruba? The Yorubas probably will say ìrẹ̀wẹ̀sì ọkàn is describing your soul being low. But then how do you distinguish between ìrẹ̀wẹ̀sì ọkàn from ìbànújẹ́? It is going to be your responsibility. In essence, what I'm saying, to even clarify emotion, you use emotional script. But you, as a therapist, will interpret that to mean and say, is this what you are saying? So most of the time, when I teach RABT, is to encourage people to have individuals describe the emotional script. We're very behavioral, we're very physical. The physicality of African culture is so overwhelming. That's why I gesticulate, you can't take it out of me. So, you may want to start with the behavior. Remember, there's this emotional C and the behavior C. So you may talk about the behavior. So I bash my wife. How are you feeling when that happened? Whatever he described the feeling, that is it. So you look at the emotional script. If it is difficult for you to use sentences for emotional script, that's where you go for figurative representation of emotions. Let's call the emotion that got you to strike your wife X. See what I mean? Let's call that X. What do you want your behavior to be? If Amina continue to behave the way she's behaving, I don't want to do that. I don't like it. What would you like to do? I would like to speak with Amina. I would like her to know how much we had talked under the mango tree and all those things. I want to go back to that. And what would that? That is your psychotherapy. And then you say, okay, fine, you've told me that, you've told me that, you've told me that. What feeling do you think might assist you? Remember, you can't change Amina. Amina is there. Let's assume you can't change her. Maybe if I felt blah, 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 they give you a script. Let's name that script why. You got it? So you've identified a functional emotion and a dysfunctional emotion. Then your job is to go back and say, when you are experiencing X that got you to slap Amina, what were you telling yourself about Amina's behavior? I was saying she was disrespectful and she must respect. You got it. So you got the start. What I'm saying in essence is that you've got to put the cultural adaptability to your practice of REBT. It is doable to find the emotion. You may not find anger, a single word. You may not find guilt, a single word that describes it succinctly. Use the script, tag the script, look for functional emotion, tag the script, and then go for it. Chase it back to find the irrational belief. I hope that helps. Sorry.
Thank you very much, Prof. Dr. Yabo Koniboboye, please kindly go ahead. Dr. Yabo, please kindly unmute yourself and ask your question and participate. Thank you. While we are waiting for if there are other comments, as we await other comments, I want to implore on all of us to please kindly ensure that we type our name for identification of our participation. Please, Dr. Owe, please kindly go ahead, sir. Kindly unmute.
Thank you very much.
Yes, sir.
Thank you very much, Dr. Abiola. We really appreciate you. And I want to say a big thank you to our lecturer, Professor A.G. Ahmed. You know, this is after our training in Arrow in those days, in 2012 or 2011, I had 2 pages of REBT, which I used for my postgraduate at my PhD level in University of Lagos. I really appreciate you because the relevance of REBT in the management of patients is quite, you can't describe the extent to which it can really help. And I want to say a big thank you to you because
Thank you.
I've been able to use it and in my research, and I got a very good results. And till
Good.
today, it's still helping me. So when I got wind of this lecture going on, I said this is an opportunity for a refresher course on RABT. So I just jump into it from the beginning, say I must be in this lecture. So I really appreciate you, sir, on the lecture.
Thank you, my
And
CMD.
if you look at the way it was so simplified, whether we like it or not, there will be antecedents. It is the belief of those antecedents that it will now lead to the consequences, which is the behavior or the emotion, which may now be maladaptive in nature. And all you just need to do in RBT is to challenge that belief. That is it. You just challenge the belief and provide alternatives. And you just discover that your patients are doing well. So I really thank you, Prof, for the lecture. Thank you, and God bless you.
Thank you, my CMD.
Yes, sir.
What? You're in
Thank
Lagos, so I
okay.
better be. Let me
Yes,
behave like a Lagosian. Twale, sir.
yes,
Twale.
sir. Thank you, sir. We really appreciate you, sir. Thank you. Thank
Thank
you so
you,
much,
Prof.
sir. Yes, sir. Yes, sir.
Yeah,
Thank
Dr.
you, sir.
Abdullah, can I speak now?
Please
Because
go
of
ahead.
moving.
Please go ahead.
Okay.
Go ahead.
Good morning once again. Thank you, Prof, for the beautiful lecture. So please, during the lecture, I think you mentioned that REBT can be used for psychosis,
Mhm.
because I think what I learned is for a patient to benefit from REBT or CBT, it must be psychologically minded. So a
Mhm.
patient that is psychotic, how do you challenge the belief?
Great question. That's a great
Please, am I
question.
audible?
And yes, you are audible. Can you hear me?
Yes, sir.
Can you hear? Okay. Thank you. Great question. When you're talking about managing individuals with psychosis, it's a question of managing their behavior. I'm a forensic psychiatrist, which means individuals who have offended are now under the review board, they can leave, and so on and so forth. And you have people who have encapsulated delusion. So in acute phase, maybe you're not able to do so. Do your superficial treatment, give them clozapine and let the psychosis, the delusion be controlled. However, there will be some deeply ingrained encapsulated delusion that may affect their behavior. I'll give you an example. The patient that I had, he had chronic schizophrenia, and he believed that he had discovered the treatment for schizophrenia, and he calls them Sunjamites. Sunjamites, nothing like that, is neologism, actually are from rotten banana. So he keeps banana, they're rotten, and he would like to feed every patient on the unit. When he went to group home, he went ahead and kept his rotten banana. No matter what I did, he was on about 1,000 milligram of clozapine or whatever, high level, but this was fixed. Otherwise, Mr. J, let's call him that, was doing very well. But he believed that, and he couldn't move forward. So the goal is this. Whenever he went to the group home, they sent him back to the hospital because he's trying to cure other patients. And he got angry. Say, I'm just trying to be of help. How then do you go about it? So do you want to stay in the community, or you want to say, I want to live like every other person, life goal. I want to be in the community. What's stopping you is because I'm trying to help people. How do you then use REBT in such cases? The fact that you want to help people, right, is laudable. It's good goal. However, do you have to help people by using Sanjamites? Do you have to? Well, they're suffering. Are there other ways? Reality, expectance, discrepancy. I want to give Sanjamite. The society will not allow you to poison the world. So how do I work with that? I will use that to say, okay, fine. Is there other way you can do it? What's the cognitive restructuring? I'm jumping all over the place to just cut to the end. Is to say, I would like to cure other people of schizophrenia, even if my own schizophrenia is not cured because I still have my delusion. I don't have to do that by using Sanjamites. I can be a peer support worker, so let's go grocery shopping together. What I've done, I'm not, when we're talking about rationality here, it's more logic within the frame of reference. What do you have in front of you? You don't have to use Sanjamite. Demand. I have to use Sanjamite. And I can't stand it. That's the script. The newer scripts that I wish to use Sanjamite to help people, but I can stand it if I'm not allowed by the society to use Sanjamite because they have a different ideas about it. I can stand it, and I can still be a useful person by helping people to go shopping together, by playing game with them, and so on. That's the kind of exercise you're doing. So yes, it is useful, and Al believes it, and that's the basis of actually the smart recovery manual that we use for forensic patient that was adapted. I hope I answered your question.
Yes, yes, Prof. Thank you very much.
Thank you very
And
much, Prof.
sorry, another question, please, for people that are interested in subsequent training, because I saw levels, different levels. How do we go about it
Uh,
for
there,
training in REBT?
well, I don't know how to answer that question. I mean, there are ways to go about it. If you go to Albert Ellis Institute or you go to International Association for REBT, uh, there are courses there you can register. You can register and then go through the level supervisors and so on and so on. I think it takes about 3 to 4 years to complete the entire process. It used to be that one was able to come down home to do so, and TJ and I are talking about how we can reactivate some things. Yeah, I don't know. Yes, Albert Ellis Institute uh, and Institute, I mean, the International Association of REBT has courses going on every now and again.
Uh,
Um,
Thank you very much.
Doctor,
Okay,
okay, sorry, this is Professor Kingsley Okunoda. I
okay.
am using Professor Owakwe's device. Sorry. Um, no, I didn't tiff it. We are in the process of making other psychiatrists. So we are in the same room here.
How is
Thank you very
Ibadan?
much for your. Yes, Ibadan is going on fine, sir. We are all in the business. Sir, there was a time you were coming to train people in this RABT. And I remember that I even paid for one. Eventually, you returned the money because you didn't have enough cohorts. I don't know if that is a possibility because now that we now have a lot of us who are interested in psychotherapy, I think it is something that you can still do, sir. If you come so that we can pay for it and we have the feel rather than doing this online that you have said, because no matter how we look at it, face-to-face training is still always better, even if it's for the prosody for this. So I don't know if you have any plans concerning that, sir.
Prof, inshallah, inshallah, let's say inshallah, we will do it. Our goal is to ensure that we have it. And it has always been that it's about time we have the African Institute. And my dream is that we do have,
Don't sit,
my
just
dream
lie
is that,
down.
no, I can't lie down. Or I can't lie down. Okay. As I was saying, our goal is to ensure, and with this group, or with Professor Dofia, TJ, I think we should be able to achieve that. It should be a delight to rekindle it. I've done some training in Arrow, as you said, done some training even in Calabar, and certainly we'll work on it. And I'm sorry, I'm sorry that I couldn't make it down. It's just that I had to bring a lot of people from different parts, because usually when we come, I bring people from US, Canada, and we come home as a team. And inshallah, we do it.
Uh, Thank you very much, Prof.
Thank you very much, sir.
Dr. Anya Chiemeka, please kindly go ahead, ask your question or contribution.
Okay. Yeah. Thank you very much, Prof. And well, to say that I'm one of your students, even though I've not completed the training, yeah, from Calabar.
Yeah.
So as always, beautiful lecture. So I was going to
Thank you,
clarify
sir.
some things. One is the thinking process.
Mhm.
It does appear, like you said, that demandiness is the most important, and the others like authorizing and frustration are derived from it. But in the event that they are seen as different concepts, is it possible they are usually combined than seen as distinct entities? I don't know if you understand my question. Like, is it the case that in the thinking process, demandingness, global evaluation, that they usually go together rather than one distinct from the other? That's one. And then secondly is in the issue of preparing patients. You said it's important to prepare patients before you start looking at the beliefs, because if not done, it could invalidate the patient. Or, for example, in
Mhm.
PTSD, you made mention of rupturing their confidence or something like that. So
Yeah.
I'm still not so clear on how to really prepare patients before venturing into REBT. Yeah, thank you very much.
Please,
Thank you
Prof,
very much.
please, sorry, Prof, before you answer, all of us on this listen, there's a pool going on, which is like an attendance. Please, kindly let's go to our chat and click the responses on the pools because it's part of what will be used for the attendance. Thank you very much. Please, Prof, kindly go ahead, sir.
Abiola, I've not got that pop-up. I've never got up that pop-up. What is going on?
My apologies, sir. If you go to your chat, if you click on your chat from your angle, then it will show you chat and pool. Then you click on the pool, you'll be able to respond to that, sir.
Okay, because I've been missing this info. Let Kingsley do it and then let me see.
Okay, sir. Thank you, sir. Please go ahead, Professor Ahmed, sir.
Yeah.
So psychiatrists who are interested in yes.
Please, Professor Ahmed, kindly answer the question, sir.
Right. So the first question was, how do you, I believe the first question related to how do you uh, distinguish, oh, what was the first question again? I know about the demand and,
Dr. Anya, kindly repeat your question, please. And please, Dr.
Okay, so
Econ
I
and
was
the rest that have questions on the chat, kindly unmute when it's time to ask the question. It's good to ask the question than for me to read it out, to be able to
okay.
express it. Thank you very much. Dr.
Okay,
Econ,
so
Dr. Yatu.
Prof, I was going to find out. Okay, I was going to find out the thinking process. Are they usually
yes,
distinct entities or they go together,
yes.
right? Yeah.
Okay.
Mm.
Right. Basically, the thinking process tend to go together if you look at it. The first thing is to demand that the situation must not be what it is. That's the demand, right? The situation must not be what it is. If you stop at that and you don't go to look for what follows next, you're probably not going to pick up the pathological emotion. The derivative is what leads you to what emotion is at stake. So, the world, what is happening should not be the man, one. And because it is happening as it should not be, I can't stand it. That's what leads to anger, right? I can't stand it. That's what awfulizing. It's just awful that it's happening this way. Or what is happening must not be happening. And because it is happening as it shouldn't be happening, and is self-directed, inserting self, it is my fault, I'm a bad person, global rating. That's what leads to depression, shame, or guilt, depending. You do further exploration to know what you're dealing with. So ultimately, the demand is that the situation that is happening must not be happening. But in order to discover what happened, you've got to look for the derivative. What is deriving from that initial cognitive distortion? If you stop at the demand, you've not done a complete job. And then what happens? So they go together within this framework. Second question.
I'm preparing the patients. He said if
In
not done
preparing the
well, it could invalidate or rupture their. Yeah.
Okay, so in preparing the patient, if you remember when we did the practicum, you actually explain what you're going to do, a version of what we've done this morning. Mr. Taiwo, I understand what the problem is. You've set the goal and say, okay, this is what is bothering me, blah, 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 blah. I say, I understand what you're talking about. The method that I'm going to be using here is based on this framework. And what it means is that the way we feel about the world is not necessarily because of what's going on around us. It is the thoughts or the way we think about what's going on around us. And my method or the approach we're going to be using is for us to identify those thinking processes that get us into trouble and see how we can change it so that we can get out of trouble. What's going on around us is called A. The way we think about it is B, and the way we feel about it is C. There are two types of Bs, the ones that are self-helping and the ones that are self-defeating. Most of the time, blah, 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 blah. So what we're going to be doing is this. So you've explained the ABC framework. Is that okay? Yes, doctor, I agree with you. So let's go for it. You've orientated your patient and you've been transparent as to what you're going to do. So they have the map, you have the map. Most of the time, what frustrates us is that you are there doing your magic in your head, and the patient is totally lost. They don't know what you're doing. So it's good to be transparent so they can work together. Can you do this for a non-PhD holding or MBBS holding Nigerian? Absolutely. Your language has to be reflective of the patient you're dealing with. That's part of the orientation. For individuals who have gone trauma, certainly what you want to do is to be very careful. Validate the emotion. I can imagine how it feels for you to have been raped at age 13. I can imagine. And then for you to meet Uncle Joe at the last Christmas party. But in what way is your feeling, the way you felt about him, that you ended up getting yourself drunk and shaming yourself, in what way is that helping you? No, it's not helping me down. So what would you like to feel? Let's assume you're exposed to the same situation. What would you like to feel? I'd like to do so, set emotional goals. So we're going to apply the system, the philosophy or the framework that I've talked about. Let's see if we can use it to help you. Orientation. That's what I'm talking about. You explain the framework, identify the dysfunctional emotion from the patient frame of reference, and then go back. That's how to prepare your patient.
Thank you very much, Prof, for giving us a formulation in REBT in a very concise way, and so that it will be easier for us to apply. There are some people who have asked questions on the chat, but it would be nice if they can please unmute themselves and ask. I know some have talked before, but nobody is saying one cannot speak more than once. Please, Dr. Obong, if you are still there, Obong, please kindly go ahead. Dr. Ayatudin, please kindly unmute yourself and ask your question. I think it'd be nice if you do that. Dr. Thomas, please kindly do the same if all of you are still there.
Good morning.
Good morning.
Thank you. Thank you very much again for the very insightful and educative lecture. I think in response to this the last question, I think my question has been answered. Even though I was asking in cases where you find the problem is there's a dysfunctional, irrational thinking at the core. And as a therapist, that is what you think needs to be done, but the client is insistent on just getting a practical solution rather than an emotional one. So what do you do? Thank you.
Very good, Hajia. I think what you're going to do is this. You will do the analysis and help the patient to understand that there's a connection between the behavior, and the emotion. And it's going to be your responsibility to say, to help them understand the connection, BC connection. You're not there as, I mean, the pastor has done it, the imam has done it, they've given support, they've given advice. What you're doing here is beyond advice. You're helping them to understand within this framework the basis of their emotional response to whatever is going on. My husband abuses me, and what if you, I mean, the pastor will say, well, you can leave your husband and go to another one or so. And then you go to, I mean, if safety has been checked, don't get me wrong. But if you have not dealt with the irrational closet, you still have the dirty laundries there, you're going to have problem on the fourth and the third and the ninth husband. So let us check it out. And that's why you got to hone it down, ensuring that they understand the philosophy, the ABC framework of emotion, using this principle.
Thank you very much, sir. Uh, okay. Dr. Thomas, please kindly go ahead.
You mentioned at some point that you use thoughts and beliefs and synonymously or synonyms, and I was thinking about how much time and energy somehow and attention in some of our training we're giving to separate and distinguish between thoughts and not thoughts and emotions, thoughts and beliefs. And so I was thinking, why would he say that he uses them synonymously? And is it specifically, for example, automatic thoughts that kind of you were referring to as using as synonymous to beliefs? Thank you.
Yeah, I think we're talking here, not your mental state where you talk about cognitive function. Cognition here relates to knowing, believing, right? Thinking. This is what I'm talking about. So when you're talking about thoughts or those internal, Albert Ellis will refer them to as loops, musical loops that goes on in your mind. I don't know about how much thoughts of, I mean, in terms of what has been given in training. I think within this framework, when we talk about beliefs, we're talking about the core beliefs. We're talking about how you think about the situation, the stories. These are all synonyms that we use. The stories you tell yourself about situations in your life. Because you've told yourself certain story, which are based on narratives, experience, upbringing. Our parents told us so many stories. One of the biggest lie they told us that you're going to, oh, you're a good boy, you're going to be a good parent. They never told me bringing up kids is a lot of hard work. Yeah? That's the sort of thing. That's part of what our culture has embedded in us. So, really, those are synonyms. There's just what you tell yourself, how you think about the situation. I can't explain it better. I wish I could.
So that's helpful, sir. Thank you.
You're most welcome.
Thank you very much. Dr. Obong, you want to go again? Thank you. I felt that I may not.
Dr. Obon, if Dr. Obon comes again, we shall apply Trump's tariff. There you go.
Thank you, sir. I felt that writing the question is good, but when somebody asks it, they may be able to articulate it better than. But if I will just try to read what has been typed. Say, please, Prof, if we are making patients more aware of their emotions?
Uh-huh.
Are we not delving into mindfulness, which is a form of dialectic behavior therapy? That was the question typed there.
Great, great question. Marshall Lenihan actually was a Marshall Lenihan actually trained with Albert Ellis. She spent most of her, before she developed dialectical behavior therapy. So let's clear that. Dialectics in terms of, you know, so mindfulness itself is something that you can combine, being aware of yourself and so on and so forth. Are they different? I think there's a significant difference here because what you're doing here, REBT is active and directive. And your goal is for individuals to take responsibility for the way they feel around themselves, about themselves, or they feel about the world and feel about. So that responsibility relies on you and in the power that you have to do the changes. If you know what your thoughts are. Mindfulness, on the other one, rather than being active and directive, it involves quietness and self-introspection. It is quite different in terms of the approach, but you're heading towards the same goal. And people, you do your REBT, mindfulness, you can also use as a tool rather than the basis. In REBT, we're very active and directive. I'm pursuing cognition. I want to see it. And I spend a lot of my time doing that. And I do it actively.
Thank you very much, sir. Please, if there are further questions, we can quickly ask them. Our time is fast spent, and Professor Dofia is still there. I know they are busy with the examination going on. That is the postgraduate
Yeah.
examination. So that's why I've been indirectly trying to carry out this task. It has been difficult for me to do, but I'm grateful for the cooperation of all. On this point, like Prof always said, Professor they always said that our session has not ended. It continues for throughout the week, where further discussion will continue on our chat group. And our active participation is one of the such things that is also being engaged and being looked at to see that people engage with what has been learned during the week. All these are being looked at and mapped out. And also, he will want me to thank Professor A.J. Ahmed because it is still early hours of the morning. Because by the time we started, it was around 3 about a.m. for him there while we were there in our own morning time, 10:30 a.m. So he has to sacrifice some of his sleeping time, his relaxation time. We are most grateful for this opportunity. And thank you so much, Sam. And like you did say that this is going to be in some series before we get to the practicum. We'll look forward to the subsequent session. Facilitate for us. And also, they have been asked that I should remind all of us that we keep respecting all public holidays in Nigeria. And next week is going to be the Easter weekend. So that we are going to have a break for next week because of the Easter weekend. And we'll continue upper week and move forward. And hoping that we also respect the exam time table for the postgraduate training. So we also look at that if it does clash with it, and the message will pass appropriately. I want to thank all our elders that are here, our teacher for today. We are most grateful for all the people that participated and are patient up to the end. And please, the sound again, there have been some pools that is taking place here is one of the means of taking life attendance. And please, we should actively participate. And also, there's some link that was sent in order for us to update people who are really interested in the psychotherapy training. Well, our number is more than the number of people that participated. About 50% of people have really updated their data space, and those are the ones that will be taken seriously, that will be participating in this activity. So for those that are there on the WhatsApp page, but they've not updated their data, they will not be considered. Because when we move forward from this introductory lecture, other things will take place. And based on this, we want to thank everyone, and we are most grateful for the participation of all. And thanks to our lecturer for today. It has been a very successful session. And thanks in advance to people that will be coming in future too. We know more people will add more flavor to this. While we keep enjoying the flavor that has been added today, we know the flavor will not end. We keep savoring it. Thank you so much, everyone, and thanks all for the participation. I do wish us a nice weekend, and we'll look forward to another session subsequently. Thank you, everyone. Have a nice day. Bye bye, all.
Thank you.
Yes.
Bye bye. Adios.
Thank you, sir.